supposed to be a couple more people, so if they come, they may just have to wait and work through it that way. But there's enough parts and pieces. If you want to sit back and watch the first one and then do one after, you can. And that way we're all covered with everything. But the idea is when you leave today, you will have a provisional implant crown that you've made that you can take home and put on your shelf. You'll be very proud of it. And there is a slight competition to it. I mean, I think that's always fun to do. So there'll be a judge, probably one of those two guys back there, totally unbiased judges.
It can be bought.
Who buys them?
Which one looks best? And Robert provided some awards for that as well. And just on a side note, these things are possible and to keep costs down because Nate and Robert have donated a lot of parts and materials and pieces. Otherwise, it would cost more to come. So make sure you thank them, and the best way to thank them is buy some product from them. Right? I use their product, so it's easy for me to say that. But they have good materials, good things. Do you guys have anything you want to say before we get started? Let me turn this on.
I know all these ugly mugs.
Great.
Meaning you.
And just FYI, we are recording it, so we have this available to you later. These microphones will, if you ask a question, you can be heard. And that's why I have a microphone on. Obviously, you can hear me, but it comes up more clear on the recording. Cool. If you don't want to be recorded, let me know. I'll have you sit off to the side so you're not in it. Just kidding. Any questions before we get started? Okay. And again, thanks for coming. This is one of my favorite things to do, and it's really fun to work through this together. Last year when we did it, it was my favorite thing we did, I think, all year as any sort of training. So it should be fun. So let's go through this. That's our study club. If you know anybody that wants to be in it, just let us know. We'll reach out to them. So we're going to go over principles of success. First and foremost, no matter how good a temporary we make, if the principles aren't followed, it doesn't turn out very good. And so we're going to talk about that, why a prototype, and then also some different techniques and how to make one yourself, which in today's world, a lot of you guys are pretty advanced in technology. So some of the things we'll show today, we'll probably develop another one to show a different way to do it more digitally. And we show some of those insights with the technology we have in this presentation. Okay. So principles of success. This is a success. Can you guys pick which one's the implant? I think it's this one right there. But then ultimately, that's what we want in the end, right? We want something that looks good. So if there's certain guidelines that we follow, most of the time it's going to turn out that way. There are times when you do everything right and it still doesn't turn out the way that we'd like. Here's one that obviously is not, right? This is a hygienist, and she wanted it to look like this, right? But this is what's happened. Bone loss, implants, visible, thin tissue. She's not very happy about it. Obviously, I wasn't involved in the beginning, so I don't know more than that. She just showed up, and this is the picture I got. Here's another one. I'm sure that's not what they wanted in the beginning. Here's another one. She didn't want a bridge. She had a bridge from this tooth to the lateral. And this is how it ended up when she moved to Idaho. And nobody wanted to see her in the valley, so she ended up here. So that's not what she wanted. And here's another one. This showed up in my office, and she wasn't really happy with how that implant crown looked. And so these are all examples of maybe how things didn't turn out right, maybe some principles weren't followed, and maybe sometimes things just happen, right? We don't know the whole story when we're not involved in it from the beginning. Here's another one. Again, probably not ideal. And here again, another one. She was in a car accident. Again, maybe not ideal. Obviously, there's a lot more involved in that one when they got to this point. So, planning. Probably the most important thing, if I could drive anything home about an anterior implant, has to be tooth-driven, right? Not just where the bone is or not just where an implant can go. You're talking about where a tooth is going to go, because they're going to be happy if it looks like a tooth. If we just go by bone and where an implant can go, a lot of times it's not going to look like a tooth on some cases. So prosthetically driven. And these are the guidelines. Simple things. The CEJ of the facial CEJ of the adjacent teeth, you want to be 2 to 3 millimeters below that on every implant in the anterior. And that's so it allows for proper emergence and papilla. This is a rule. I think if you're going to go by any rules in dentistry, if the bone is here and we're greater than 5 millimeters to where the contact is, that is not going to fill in. At 5 millimeters, you're down to 70% chance. 6, you're down to 30% chance. 8, you're just not going to get there. Does that make sense? So if we're looking at it, we have a lot of digital technology available to us today that we can see where that bone's going to be probably from the beginning and be able to tell them realistically what to expect. If it looks like it's going to be a question, but they still want an implant, then they can know that before they even get the implant placed. All right? Here, this one I think is super critical just because we've been doing anterior implants now probably for 20, 30 years. And how many of you have somebody come in and you see the dark line of where the implant is, right? The reason you see that is because this facial bone's really thin, sometimes not even existent, and then you see the implant showing through the tissue. It's just kind of what happens. And in the past, we used to think, hey, we have this much bone, we can get this size of implant in there because we have more surface area to do that. And it's not that long ago that we thought that way. But the reality is we need this 1.5 millimeters to 2 millimeters, ideally 2 millimeters on the facial surface of your implant to keep that health and stable for the long haul and aesthetically pleasing for the patient. All right. And here, this is just a reminder of in between, how much space we need between a tooth and an implant. Really, it comes down to, go back one. It comes down to blood supply. You know, they say the minimum between a tooth and an implant is 1.5 millimeters. Between implants, they would say 3. In today's world, that 3 is probably not there, maybe more 2. But the reality is what kind of shape of a tooth do we want? You know, how much blood supply do you think we'll have there to be most predictable? You know, if you have one thing I see a lot is say, and this is on the posterior, apologize, say here's a premolar, here's a molar, but we don't have anything behind it. So we err on putting it at 1.5 millimeters right here. So that's really close. You'll get a premolar there to look good, but if you put a molar, it's going to have this cantilever back. Or the other is someone will put it in the distal root, and then you have this huge cantilever forward. So just find out where you want that tooth to be, what size you want it to be, and put it where it's going to best support that implant. Okay. This is a little bit of information there on the... So we'll just review this real quick. On a Pontic, you can get better papilla at times than you can on an implant. If there's implants side by side, that's where you get that, is that bone in between seems to be a little bit deeper, and sometimes a Pontic allows you to get more fill around that fake tooth. They say about 6 millimeters you can have from where the bone is and where the contact is to have the papilla fill in. And so just be aware of that. If you're looking at implants side by side, sometimes you have to. Size of the teeth, you just feel more predictable, or the bone isn't adequate, so you feel like 2 implants is going to be better. But then you have to tell the patient the papilla is going to be harder to gain in between them versus a Pontic. Okay, so here's just some examples. This particular patient had his teeth moved, wanted to do implants. We looked at it and planned the implants and said, you know what, there's just not enough bone there for implants. So he had to elect to go through grafting. The reason I put this in is even if you slid one in there and it goes in, that's not very predictable long term. So what I find in the literature is if you graft ahead and augment that, you're going to have better success than if you try to put it in and graft at the same time. Even though there's people doing that, some people have good success, but it seems like long-term predictability is you graft ahead. In his case, he decided he didn't want to do anything, so moved the canines in, and we didn't do implants. Here's another one. This is an example of, I think, more of an ideal scenario. Going back here, in our planning, we've designed a tooth to be as ideal as possible, location, shape, size, form. We go in and merge that with the CT scan, can put the implant in virtually. It's coming out great for a screw retained restoration. We have about 2 millimeters of bone. This little shadow marks 1.5 millimeters. You can change the settings in your implant planning software to what you want that to be. So we just know that little outline is 1.5 millimeters, and we have another about 0.5 millimeter or so out there. So 2 millimeters, that's ideal. That's great. That's, as far as we understand now, that's going to be very predictable. we may change in 10 years. And then we have about 1.5 millimeters here. And it's screw retained, so it turned out great. Here's another case where they came in and they wanted implants here. They were mid-ortho, and they just weren't satisfied. They wanted to get implants in. So we continue to go on. Again, kind of same scenario. They grafted, and now they're ready for their implants. But it was done in advance. And there's the planning. You can see how they move the roots more ideally, and there's adequate room to put those implants in. Okay, so I think always a cone beam CT, and at least I know you guys, that's like a no-brainer. That's just what we do. I don't know why we wouldn't do it. Diagnostic wax ups, especially on anterior teeth, I think are critical. If we were to jump back to that lady that had the 2 green implants stuck way up there, the thing that finally helped her understand where she was at is I did a wax up and showed her this is what we can get, and helped her see it. And so it's really important as you do that wax up, do the CT scan, merge all that data, you can give them a really good idea of where we're going to go, what it's going to be like. And then surgical implant planning and the guide. So here's just the case. This is the case actually you're going to be working on in the lab. So she had this tooth knocked out by her boyfriend. Obviously they're not boyfriend and girlfriend anymore. And we just merged her digital impression into the CT scan, and then we did a wax up to merge, to give us an idea of what that's going to be like. You know what you can do for me? Can you turn that middle light off? I forgot to do that. So you can see it better. There we go. Again, it's in position to be the same size, same shape, best position. There you go. You can see it from the occlusal, and that's where you're going to plan where your implant goes. So from there, we plan the implant. It looks pretty good. We felt pretty comfortable with that. Again, when the tooth got knocked out, it was grafted previously, so it's not just healed. It's been healed and grafted, and this is the way it looked. Again, positioning. Here's where you can tell. This is kind of a weird view, but you can actually measure in some of these where the bone is and where the contact of the teeth are, or where you'd expect it to be. And that's where you can make a decision if you're going to do both. Sometimes doing a front tooth is better no matter what to do both, because you get the control of the aesthetics, but you can also control better where the contact point is. Tapered teeth are definitely teeth that you may want to consider that, so you can get more predictability of where that papilla is going to end up. So there it is, and a guide was made from that. Okay, why a prototype? I like to call it that. Insurances don't cover temporaries, I'm pretty sure. And so patients don't want to pay for one. So a lot of times you'll just make one or just say, you need this. So why do we need a prototype? Anyone know? Why would you say that it's necessary if you did? Any thoughts?
The contours are so you can adjust it for the tissue.
Great. Any other thoughts? I mean, it really tells us what it's going to end up like in the end, right? Before you invest in a final. Last thing you want is to go to the final, all of a sudden you see these changes in the tissue, and you can't really change the shape of the crown unless you make a new one, which is more expensive. If you're doing a cement retained crown, because sometimes, no matter what you do, you're going to have a cement retained restoration. Now, fortunately, the implant companies have improved tremendously, and we have those angle corrected screw channels up to 25 degrees. I think Straumann now has one of those as well. So it helps us, but if we were even considering a cement retained, that tissue needs to be developed and stable before we cement that in there. Otherwise, it's really hard to control where that cement goes. So it also helps the patient see. I always explain to them, we're going to do this prototype because this is your front teeth, right? You want this to look great. And they always say, yes, I do. I want it to look just like my teeth. I said, we talk about the limitations of what we can do, what we can't do, and how a prototype lets us see ultimately what's going to happen. You can then take a step back and say, well, maybe we need to crown lengthen some of the other teeth. Maybe we need to change the shape of the other teeth to make sure that papilla fills in better. And so you're planning it instead of going back later saying, we should have done this, or now we got to do this. Personally, I hate going to the mechanic, and he's like, well, now I found out we need to do this. Well, sometimes that happens, right? But if we can prevent that, we build trust and give them the best result possible instead of backtracking, going, well, I guess we could have done this or this or this. Okay? Okay, development of the soft tissue, evaluation of the aesthetics, predictability, growth and development, and patient comfort. Those are all reasons why we do a prototype. Helps shape and support the interdental papilla. Is everyone feel comfortable with how you do that? I'm going to draw a quick picture just to help illustrate that, just because I think sometimes it's hard to see. If you have a pontic or a tooth, here's your implant, and it comes off this shape like that, okay? You'll have soft tissue that comes and fills in here, all right? So if you're looking at the facial, and here's your natural tooth, and here's your implant crown. Hang on. And then you observe and say the tissue covers this up more and it looks a little shorter, just by chance. If you change the contour of this out here, it automatically pushes that soft tissue down. Does that make sense? So that's what you're trying to look at. If that tissue looks too tall, you change the contour, make it a little more bulky, it kind of pushes the tissue up. And on the flip side, if you're looking at it and now your implant restoration just looks a little longer, right? What you would do, and this is kind of, it's not changing the tissue per se, it's not making it grow, but if you thin it down a little and then bring it out, it sometimes will allow that soft tissue to just fall down a little bit taller. Does that make sense? So it makes it look like it's longer. Because ultimately, a lot of times you just can't bring that tissue down. And so that when it does that, sometimes it'll look better. Does that make sense? And same thing in between the teeth. So if this was our implant, likely our papilla will not go all the way up in there. Okay? So if we change our contours of our crown, we can change where the support is on that tissue and see if it'll support it better to push it up in there. Does that make sense? You can also change where your contact is. On this tooth, it'd be hard to change where your contact is unless you did both. Does that make sense? And now your papilla fills in all the way. So that's what I think is one of the most important reasons why we would have a provisional, is to develop that soft tissue and observe how the other teeth fit in with it. Right? Ultimately, if you just can't get this one to look like it matches, maybe you can crown lengthen that one a little bit. Even if it's just aesthetic crown lengthening, you have to do a crown or anything else on it, you just change the shape of that tissue. Make sense? So it's really important as you make your temporary today to understand what you think that tissue is going to look like. You know, what the shape of that temporary should look like. I'd say today just err on making it look as ideal as possible. Does that make sense? Just get used to how does that come out of the tissue. All right, and we just talked about those. And you can evaluate if you need some grafting. If that tissue is really thin, you can go back and graft it. Okay, so here's just an example. I know there's a lot of different techniques out there about doing an implant and a temporary at the same time to help preserve or protect that gingiva. There's some where you actually take a tooth out. They say put the implant in, put the temporary on. There's actually people advocating that that's the only way you should do it if you're going to do it. I think for most part that's really good if you can do that. Like if you understand how that works and you can be predictable, that's great. For me, I honestly like to do it this way still. Build the bone in advance so you know you have enough bone. We put the implant in and let it heal over. As you see here, there's still some papilla there. It's not completely gone. But I like that, and my reasoning is when we go back to uncover it and put the temporary in, because where that healing abutment would be or that crown, they've had tissue grown over there. So now you have some extra tissue that ultimately you can tuck in underneath here if you need to. Does that make sense? I had a surgeon just do that for me the other day. I'll show you some pictures of that in a minute, but it usually ends up really nice. You have extra tissue to work with, and ultimately in the end, biology is going to dictate what happens here, not because we put an implant in and a provisional right away. It's because the bone levels are in the right spot. The contours of these teeth, the contours of this provisional are going to be correct. That's what's going to maintain it. And so we made it temporary and ultimately ended up like that when we were getting ready to restore it for long term. So, I mean, he didn't have a tooth there for a while, but it's hard to convince me that that's not going to look good in the end because the biology is adequate and correct. I think if we would have put an immediate one in his case, it probably would have turned out good because it's going to be fine. Okay, here's another one. Another reason for a provisional. This is that lady you saw earlier. Obviously, that's a huge crown. Looks weird, out of position, facial. When they put it in, she says it shifted her teeth over this way because there's a cant to it. So ultimately, we put her into a provisional and started through orthodontics and started to thin it down and reshape it as much as we could to see if we could get it to look good. Does that make sense? Before we went to something final. In the end, let's see. We thinned it down, again, as much as we could. Just the inclination position of that implant was not going to allow for a normal, matching appearance of a tooth. Even with crown lengthening, right? It's not going to ever match. So she got to see that. She elected, was one of the options, to just not use that implant anymore. So we did. We buried it, grafted over it, and now she's almost done with treatment. I don't have those pictures in. But that's a great reason for a prototype. I have to see, what is this going to look like? And she helps understand that before it's done. And her expectations are normal. Does that make sense? Okay. Here's another one I mentioned earlier, that growth and transition. This is kind of on the edge of what we do today. This person has ectodermal dysplasia. We're always taught to not do implants in people until they're done growing. This boy was 15 at the time and has lived like that his whole really teenage years, right? And he wanted something different. He's had a snap-in smile, which I think was this. There's a snap-in smile and a retainer. And then what we decided to do was put some implants in. And so he's got 2 implants here, 2 implants here. He's got a provisional and then an implant bridge here. And he's been in that. He's 19 now. So it's just a different way to give somebody something in the interim time. He's happy, he can chew, he can function, he felt more normal. Obviously, we wouldn't do anything definitive until he was done, but it gives us the opportunity to put him into something definitive later. Okay, any questions about that? I'm going to show you one more case. This person came in and this root was this long. So she's going to lose this tooth. So we took it out, grafted it. That's just, the surgeon wanted to do it that way, that was fine. And we bonded her tooth in. So that's her tooth while she's healing from that. Then actually she healed with that while the implant was placed too down in there. Then we made a provisional. There it is. She waited a while because of school and being away. And there's her implant provisional, I think at a year. So tissue turned out really good. And there's her final. A little bit of blanching in there, but the idea there is you want your final, if you develop your provisional the way you'd want, to fit exactly the same. So that's, if you're working with a lab and you get it back and it changes your tissue, I'd talk to them and change it and give it back. Does that make sense? Because they should be able to follow. If you've replicated your tissue contours in your impression, and that's the way you want it to look, it better look that way. Because it'll change how things end up if you don't. So the first time this came back from the lab, just to tell you a little insight, like it blanched all this tissue because the contours just weren't right. And I was like, you guys, I have a custom impression. The reason is I developed that tissue to look a certain way. And so you can talk to them and make sure they follow that. If they don't put it in because it'll change your tissues. If I would have put it in, it probably would have pushed your tissue further up and then it would look a lot different than the other side. So there you go.
Are you going to talk about how you impress and capture that tissue?
You know, today I can. I didn't put it in the lecture, but I can, for sure. Do you want me to do it right? It is a trick. So I'll just talk about it real quick, and I can show you something afterwards, like a little presentation of it. But what I do is, because as soon as you take this out, here, let's get to the, so as soon as you take this out, guess what happens? Within seconds, right? It just, whoop, slumps down. So everything you've developed for a year in this case is gone, almost everything. I mean, it's just a water balloon. So as soon as you take that out, that seeps down. So what we like to do, there's a couple ways to do it. Some people have a stone model and they put an analog in it. The same, some people, whatever implants they're using, they'll have multiple ones out. You take this provisional off, right? You screw it down on that model, and then you inject around it impression material. So now you have an impression of the part you don't see underneath of there, right? So you have the exact replica of the shape of that provisional. Then you take your temporary cylinder, put it on, and not your temporary, your impression cylinder, put it on, and then you inject flowable around it to replicate the exact shape of the provisional. Does that make sense? So now when you go back to the mouth, you can put that back in, at least it's getting that shape. Because ultimately, if your lab can replicate the exact shape down here, right, that's all you're really getting. Even if the tissue still slumps down, because likely it'll still slump down even when you put that back in, but that provisional, or the impression now is going to replicate the exact shape of the provisional. Does that make sense? So that's a simple way to do that. I don't pour stone models or cylinders. I just have an analog, screw it on, and just inject around with impression material around the base of it. Then I unscrew it, and then I put the impression coping on and put composite in there. Does that make sense? That's how you can do that. Is that how you guys do it? Yeah. I think that's the best way. Your staff can do that. Like, you guys can easily do that for your doctors. Have everything ready. Okay, some different techniques. These are kind of cool. At the stage of planning, what does that mean? So we just planned this case, right? We printed models then. They did the surgery on the cast. I think in today's world, they might even be able to replicate that. But just to be safe, you do the surgery on the cast. You mark where you're going to rotate that implant to. So in surgery, you can do the same. And you can make, there you go, there's an example of it again. You can make a provisional, right? So say your rotation's off a little bit, and you're like, ooh, you can just modify that provisional. Or you can just have, you can have this temporary cylinder there and a shell made, right? So you put the temporary cylinder in, this is just a tie base, and you pick that up in the mouth. You make an index of your crown that you have on the model, you put it in, and you just inject flowable around that. So it picks it up in the mouth, and you can finish it completely out of the mouth and put it in. Does that make sense? You can also have, so that's showing the shell. You can also have a custom healing abutment made. And that works really nice. In the case that you're working on, that's actually what we did. We let it heal with a custom healing abutment, just because all the parameters looked really good. And then, so those are the 3 ways that I know of that you can do something at surgery. Oh, there's one more actually. Oh, that was at planning. Then at surgery, you can index an implant. This is the traditional analog way. You place the implant, you put the impression coping on once it's in the bone. You can use your guide, hollow out your guide, and lute it to your guide. Does that make sense? Now you have, hopefully, an exact replica of the height, position, angulation, and orientation of that implant. What you do with that is you take it back to a model, and where this implant is now placed, hollow that out completely, cut it away, put an analog on that impression coping, seat it on the model, and attach it to the model. Then you can unscrew it, and I have an analog in the model. Okay? The video you're going to watch is actually done that way. There you go. See how that worked? We cut out this area, and in this case, we just injected acrylic in there, and I have an analog down in that model. Another way is using a scan body. This is great. I think all of you guys have digital impressions. Did you get one yet? Still haven't got one. Do you have one? You have Trios, right? No. Carestream. Cirac. 3M. But you can use these scan bodies. Now the difficult part here is you just have to, it's not really that difficult. You guys probably already know because you know your system. You have to know which scan body best correlates with your implant and what your lab or your machine's using. Once you know that, then you're fine. But you can scan it at the time of surgery. And that way you can print a model, make your temporary, digitally make your temporary, so that it's ready at the time of uncovery or at the time you place your implant. That makes sense? So here's a video of us doing that. Oh, did it already play?
No, it's playing right now.
Oh, it's playing right now. Okay. So this is 3 shapes. It just shows, we tell it what we want it to be. There's a picture protecting the innocent there. And you can put details on it if you're going to send it to the lab. And it's set up. In this case, you do a pre-scan. This just shows how the 3 shape works. Scanning it. This is a part that, as we get to the scan body, you have to have enough of the scan body visible to correlate in your software. So every software is different. In our software, we can tell it how much is exposed, so it does a better correlation. But it scans pretty quickly. We're just going to speed it up here for a matter of time. So there you go, there's the scan. Okay, then in our software, it'll tell us to go put the scan body in. And I apologize, if you look really closely, that is not the scan body. That is actually the custom healing abutment. But for whatever reason, the video didn't turn out with the scan body. But you'd put it in, right? And this is the part that's tricky, keeping that tissue down, keeping blood away. But I think it wasn't too bad. Once it's ready, we go back in and scan again. And this time it just scans the little area, so you can see it sticking out there. The surgeons I've been working with on it, sometimes they'll just put a little stitch around it to help keep it in place. But there you go. And then we send that off to the lab. What I didn't show is we scanned the opposing arch in advance. You send it off to the lab. Okay, pretty easy to do that. This is the lab part. And I'll just run through it really quick. I mean, everybody's software is different, so nobody has this software, so I understand that this doesn't relate to anything you're doing. But you would go in there, design it, and basically do an ideal contour and shape of a provisional. So I'll skip that because obviously this software is awesome, by the way. If anybody ever wants to get it, I'd recommend it. You can use any STL. Exocad. And you can do anything in it, really. Jones and I are going to go do some more training on it in a couple months. There you go. So now you have a screw-retained provisional. There you go. Cool.
So you're doing that full design and exporting it to the lab just...
Right now, the lab's doing it for me. Chris and I, we're going to go get the training so we know how to do it. We kind of know how to do it. Like, we can do full arch implant cases like that, which doesn't make sense, right? Because this should be easier. We've just been trained in doing full arch implant cases. But yeah, you can even have your staff learn how to do that, design it, you approve it, and get it milled or printed. So, okay, different techniques. These are Straumann's temporary components. This is, since this model has Straumann in it, and Robert's here supporting us, and I use Straumann, that's why it's in here. This is the temporary cylinder. This is the new temporary cylinder. What do you call this?
Which one?
The peak?
Sure.
Is that what it is? Okay.
VitaCat.
This is kind of cool. It allows you to do it more in the mouth. It's already got some composite on it there, and you can prep it and have a matrix in the mouth and finish a lot of it in the mouth. So I did one of these the other day just because I wanted to see how it worked. It was kind of slick. So I usually use this one because it's usually stronger, but this does have a titanium insert in here. So this is at surgery or after healing. You make an impression. Oh, here's the pictures from the other day. Don't mock my preps. I haven't touched them. They came like this, okay? So we're working on them. But,
excuse.
right? Well, yeah, anyways. I remember when Jones gave a lecture once, he called me out on something like this. I was like, so I'm prefacing that. But this is also, these were 2-stage, was grafted in advance, bone looked great, implants placed, healed over, she wore a provisional temporary bridge over here. And then the day of uncovery, he took some of the palatal tissue and folded it up underneath here. Does that make sense? So we had some extra tissue to work with. It's going to heal by some secondary intention, which I know she won't be really happy about when I see her next week. She'll, what is this? We talked to her about it, but it'll look good in the end. But these are those temporary abutments. We prepped them down, and
We're just talking about the interproximal areas, just left them denuded.
yeah, because he didn't close all the way here.
Yeah.
So it's going to heal by secondary tension, which the papillae are going to take longer to come in, but ultimately, hopefully, they will do what we want them to do. But these are just prepped down, checked her bite, she had clearance for the materials, and then we just went through and made her some provisionals. And again, focusing on the right contours here and supporting the tissue here. And so we'll see how that heals. We can take them in and out and adjust them as needed as things heal.
This was that composite sleeve
Yeah.
temporary?
So it was pretty slick, actually. My staff made the comment like, this is pretty nice. This was, and so it's the first ones we've done like that, but they turned out really good. And we'll see how they last, right? It's a little bit different way. We'll see. Here's the other way is you again make an impression. That one I didn't make an impression. We did that all in the mouth, right? We put those in, prepped them down, took our matrix, made our temporaries, and finished them in the lab. Or you could do it chair side, but we have a lab, so we did it here.
What was the material you overlaid them with?
Composite. So we roughened it up, bonded it on there, and then flowable around where we needed the contours to be. Oh, that's the video. So this, any questions about anything we've done so far? Because the next part is actually the video of how to make a temporary using these parts and pieces, which is what we're going to do in the lab. Robert supplied, I guess he provided, wrong way. He provided those other ones in there if you wanted to try to make one, but I don't have a video on how to do that. So these parts are in the little kit that's in there, so you can see them, feel them. Do you mind if they prep them or anything like that?
What's that?
Do you mind if they prep those?
Yeah, they are just like that right there.
Yeah, so if you wanted to play around with it, you could. But like I said, the video we have is showing this part. So in this case, we waited and made the impression technically in after it was uncovered. We just made the impression, came to the lab and made the temporary. No, wait. We did not do that. This is the one that we made a custom healing abutment and made a custom impression. So this is actually a different case you're doing that we're going to show, but it's a technique you're going to do in the lab. Does that make sense? A little confusing there. Okay, so this is it. Should go through it. So just this part, just so you know, it's just showing how to put it in the model. That's already been done for you, so you don't have to worry about that. But if you were going to use this technique, this is what you would do. You would put the analog on and then keep adjusting it until you know it goes down. So obviously it's not down all the way, it's rocking, it's not seated. So you go adjust it some more, and you'd want it passively in there, like not touching any of the sides, so you just know it's seated all the way. And that you're hoping too the guide was seated all the way, right? So you have windows in your guide. I don't know if you saw those to just verify it's seated. And then this, we just used acrylic, quick set acrylic, mixed it up, put it in a monojet syringe, and injected it down around the analog so that it's stuck in there. This model is a printed acrylic model that we use for diagnostic purposes and just drilled off the tooth. You can use composite, whatever's easier for you to put in there. Some people use gutta percha. They heat it up, inject it in there. But yeah, just make sure it's in there. We have most of these things set up for you, I think, in the lab, so it should go pretty quickly. There you go. You can see we didn't fill in that little hole, but it's in there solid. So. Now, if you have a wax up of the tooth, or if they like the original tooth, if you have a model of it, you can then make a putty index or some sort of matrix or index for the temporary. In this case, this was her original tooth, and we just made an index of it. Again, the index is already made for you, so you're ready to go when you're in the lab, just to speed up some time. But you would, and my hands really move that fast. There you go, especially that. I like using that putty, it sets up really fast. Okay, now you'll put your temporary cylinder on, tighten it down, and evaluate where that's going to fit within your tooth. Does that make sense? Then you'll mark it so you can trim down enough of that temporary cylinder to fit within the tooth you're making. This particular tooth does not obviously come out the lingual, so when it's screw retained, it's going to have a hole in the incisal edge, but we still cut it down to make sure it fit within the confines of our tooth. In the lab, we have some stations set up with a disc and some set up with stone wheels. I like the stone wheel personally. It doesn't make the metal get as hot, but whatever one you want to use, you can use. So we cut it down, check it again. Now we're just marking on the cast where the access hole is, because once you've put your temporary material over it, you don't necessarily see that, and so you have to be able to drill down through your temporary to get to it. So we mark the buccal and lingual and the mesial and distal. You can see that on the model. Some people have a suck down made ahead of time if you want to do a clear matrix with a dot on it, and you just put it back over it and you know where to drill through it. This is opaquer. We're not doing this step today just because I don't have that much opaquer, but I found if you block out the color of the temporary abutment, even in this case where it's gold, it's supposed to not show through as much. If you block it out all the way around, I've done it where I've just blocked out the facial thinking that was enough. I've done it where I didn't block out the access hole, but that metal color can reflect through that material. So we try to block out the whole, all the surfaces of it. And put it back on. There you go. We try on the matrix, I believe, next, just to make sure. Oh, actually we didn't. This, if you poured up a model and you have soft tissue on it, there's almost always undercuts where the soft tissue was. So this is just showing where you would block it out with Play-Doh or impression material, whatever you'd like. This is just lab block out. My predecessor had it in the lab and there's still that much left. So obviously, if you have Play-Doh or something, it's easy. So you block it out so you don't get it stuck on your model.
You mean like kids Play-Doh?
Yeah, you could do that. And then the next step is you would put some sort of separating medium on it. I think in the lab, Chris put out there some Vaseline. So you just paint a light coat over it, so you just minimize the chances of that getting stuck to your model. Especially if you have an acrylic model and say you're going to use an acrylic temporary material. That gets pretty tricky. We're using temporary material from GC, BIS GMA in the lab with flowable and stuff. So there you go, put some separating medium on it. I would recommend not keeping that on there when you do it, your temporary abutment, just because if you get that on there, then it increases the chance it's not going to bond. So take your temporary abutment off before you put your separating medium on and then put it back in. This is just blocking out the holes so you don't get it down and around your screw. Lots of ways to block it out. We have cotton in the back, cotton roll. You cut it, take a little piece, put it down in there. You can use wax, you can use Teflon tape, whatever you need that you feel like you can get out of there pretty easily. There's your matrix. Good, everything fits. And now we just get our material and put it in. A lot of times I'll inject it down around it just because I want it to get on there. But look at it, if you're afraid that your implant analog is exposed and you're going to get it locked in somewhere, just be careful where you put it so you can get it off later. There you go. We get it off, and you can see the lines. We'll try to identify where that access is. This part is kind of tricky. We give you a little round burr to drill down through it. Most people want to just go for it. Like, I'm just going to go fast and go for it. If you do that, it's going to bounce all over the place and maybe even break your temporary. So you just turn it on kind of slow, good pivot point position, and drill down nice and easy through it. And I'll guarantee you, I don't know if you saw me do that or not there, once it starts to go in, it wants to go, and it'll make a big hole. So just be really careful. And once you get down through, you just follow the angle down, and you get down to your cotton. There you go. And we just go and make sure. Sometimes it'll be off just a little bit and your driver or screw doesn't want to go in. So just look down it and see if you need to smooth that out or change the orientation a little bit. There you go. Then we'll take it off here in a second. We have hemostats to help you do that if you need it. And then we have a rubber wheel. I love those things. Kerr actually makes those. And they're great to just refine and fine-tune temporaries. I think that's all we use in the lab now for almost all of our temporaries. It's just great. I don't know if it'll show it or not on this video, but you'll see it in there. It's a little gray disc. It's about 3 millimeters thick, about 10 millimeters in diameter, and it's on a mandrel. Some of you will have to put it on your mandrel, and then there it is, just like that. It's like butter. So be careful when you use it. It's just nice. Now you'll see here, take a pencil or something and you see where the contours are. So you can hold it up, because sometimes temporaries or the materials don't let you see exactly what it looks like. So if you draw it on there, you can then go back and reshape it to where you think that tissue needs to follow. And then once you're done, you're done. The polish is, I like to use, honestly, the BIS GMA. There's composites so you can layer on it if you want to make it look better. I don't know if it's just the patients I get, but all of them want it to match just right. So I almost always have to go back and layer some composite layering on it. But it's easy to do with that. You can cut away some of it and put your bonding agent on it and relayer some composite. There you go. Now polishing it, we use the pumice in the wheel. It's in the lab. Just come over there and polish it if you want. Again, there's a competition to see who makes the best provisional today.
There's money involved, truthfully.
Oh, there you go. So there's the provisional. Okay, and here's the case actually. It was part of the other case I showed, but there's the temporary shortly after it's uncovered. And there it is a little while after. Okay. This video, if you wanted to pull it up while we're in there, it's on YouTube under Boise, or it's either under Michael Gurney or Boise Prosthodontics, and it's labeled as the Strawman temporary fabrication. So if you want it on your phone while you're in there working, you can pull it up there and look at it if you want to check any of the steps. Any questions about that? You guys ready to go?
There's plenty of product, there's a lot of spread out,
Oh.
so there's a couple of different bottles of bonding agent, and we tried to, didn't realize we were as spread out as we were, so we might have to
So
swap
what-
some temp material.
In here, there's 3 stations. So there's some of the product you just split between the 3, so you just rotate with it. In the other room, I think at each station there's a 1, 2, 2, and then 2, and they all have product at each one.
In those
But just
rooms,
show-
there's bond and cement, bond, composite, and temporary. Just we might have to swap one. I didn't realize there was going to be so many stations where I would have brought individual dosages.
No problem. All right. So Jones, will you walk them into the lab, the Precision lab? By the way, thank Precision. They just let us use their space. Some of the instruments they're letting us use too, which was nice of them. And let's go.